Hi, everybody. Welcome to Fact or Fiction, fertility fact or fiction, where Tarek and I are rapidly losing our minds at the start of the show. Thank you for joining us. We have a good show for you, as always. And some really amazing things have been going on in the fertility world and with us. So lots of exciting things to talk about. And a great topic, which is really important to me because we focus a lot on the mental health of our patients. We have an incredible program to support our patients that are struggling, and even the ones that aren't struggling, because sometimes it's very silent and people don't even realize they need help, but they do. So we've got all sorts of resources for our patients. And, because of that, we wanted to go over this because it actually shows how some of these mental health issues can actually physically impact the quality and the outcomes. So very cool study out of China. It's upcoming in fertility and sterility, and so I'll be sharing that with you soon. We had some very interesting news here in Windsor today. The Premier of Ontario and the Minister of Health both joined in Windsor, Essex, to talk about funding for our new hospital, which is kind of around the corner from us. And we are hopeful that in the near future, with some luck, they'll turn to funding our IVF program as well. So fingers crossed, with some luck for 2022, we may end up with some fertility funding here. And we are working hard on that to make that a reality for everybody. And we will obviously keep you apprised of what happens as we go through it all. Borders opening soon, so we're expecting lots of our American viewers to easily come and go. And that should make things pretty exciting for us as well. So we know already that many American patients have started coming over, and now it'll be even easier with travel going back and forth. So we're really excited about the future and what it represents. Tarek and I are going to have to mount an advertising campaign in the US. And interesting for us, and unbeknownst to us, YouTube started advertising on our YouTube channel. So I guess we've become popular enough that they've started advertising. So that was kind of exciting for us too. I guess it's one of the signs that you're making a little bit of an impact in somebody's world. So kind of cool little things that are happening that make this kind of exciting and rewarding for us. So I wanted to share with you guys this article. So this article is called Associations Between Depression, Oxidative Stress, and Semen Quality Among 1,000 Healthy Men Screened as Potential Sperm Donors. So very, very interesting stuff, and a great little study. So I wanted to kind of go through this with you to discuss it. The study was conducted from April 17th to July 2018. It's in the Hubei province in the People's Republic of China. I apologize for my geographical ignorance, but I have no idea where Hubei province is. If any of you do and you're watching, then let us all know. Put it up on the message board there, comment. And don't forget to subscribe to our channel and like, comment, and share. That's always super important for us to be able to help you guys out. So in that time period, they found 1,487 healthy male volunteers, and they were all coming in as potential sperm donors in this one particular sperm bank. So their donation criteria were that they had to be between the ages of 22 and 45. They had to at least have a high school degree or higher, no genetic diseases, for example, thalassemia, no history of clinically diagnosed mental disorders, no sexually transmitted diseases that were significant like HIV, syphilis, gonorrhea, and no severe systemic or organic diseases of any kind of sort. The ones who met that initial criteria had to have sperm criteria, so they had to have at least 60 million per mil, progressive motility of greater than 60%, which is quite high, and more than 30% normal morphology, and then some frozen criteria as well. So they included multiple sperm samples in their analysis for guys that provided multiple samples, obviously. And then they gave them the Beck depression inventory and scored them on what they were like at entry. So this is a standardized depression scale that's used in many research protocols. so that they can assess on a numeric comparative sort of baseline how depressed or not depressed you are. So out of the 1,487 men, they had to exclude 102 because they either had a genetic problem or an STD. 379 because they lacked enough data on the Beck depression inventory, which is really unfortunate. It's almost a third of the study population, a quarter to a third. 5 were excluded because they didn't have oxidative stress markers, and 1 because it was missing some covariate information like age and weight and stuff like that. So basically for the Beck depression inventory, they have cutoff scores. So a 0 to 4 means you have no depression. A 5 to 13 means you have mild depression. 14 to 20 is moderate, and then greater than 21 or on is severe depression. So just keep those numbers kind of in the back of your head as we go through this all. So interesting population. The average was 28.1 years of age. So relatively young guys. So you're going to assume that most of them are young. They're healthy. They're probably going to have pretty vigorous sperm. Body mass index on average was only 22.9. That's probably, several points, if not more than, 8 to 10 points lower than we'll see in North America. And on average, they had waited almost 0.2 days from the last time they had ejaculated before they gave their sample. About 2/3 of them had a bachelor's degree. 57% of them were non-smokers, and only 11% drank alcohol at least once per week. So not exactly the average North American population, but probably not far off either. Just the weight is really kind of substantially different. So when they looked at the factors in their demographics, they did look at the excluded versus the included. Out of the ones that were excluded, there were some differences. The marital status was different. The smoking status was different. So those two things had a little bit of resonance. And then they looked at income, and that was a little bit different as well. But this was just to say that the people that were excluded were, potentially a little bit significant. So there are some concerns with the fact that they extracted some of these people because they didn't have adequate data, because there was a bit of a difference. So you've got to include that when you're analyzing the validity of the data. So we're going to go to table 2, and Tarek will pop that up on the screen for us. So table 2 has the majority of the data there, okay? So you've got your Bdi scores. So the average for no depression, obviously 2. Mild depression was from 6 to 10, so about 8. Average for the moderate depression score of 16. And then in the severe depression category, an average score of 25. So when they looked at the markers for oxidative stress, they had several different factors that they looked at. They're all listed there. Basically, it's not that important because they found that despite the fact that some of these men were severely depressed, there was no difference in the oxidative stress on the sperm. Why is this important? There are studies that show that oxidative stress on sperm increases the sperm DNA damage and decreases the sperm function, and it has been linked to poor outcomes. So you don't want your sperm to be getting a lot of oxidative damage because that's bad. How do we undo oxidative damage? No smoking, no drinking, no drug use, frequent ejaculation, lots of vitamins. In particular, vitamins tend to have an antioxidant property, so that's the main one we use for that purpose. The interesting part is when you get down to semen volume. So as you can see, in no depression, the average was 3 milliliters of volume, but then it starts to drift down. So 2.8 for mild, 2.5 for moderate, and down to 2.2. That was highly significantly different between the groups. So you're losing almost a full mil just for being depressed. And that's a very substantial finding. And keep in mind, these are guys that are giving 5, 6 samples each. So they really were seeing this over and over and over again. Same thing with the sperm concentration. You're starting out at 62 million per mil, drifts insignificantly down to 61, again, insignificantly down to 60. But then in the severe depression group, drops as far as 50 million per mil. When they looked at the total motile counts, you see a very substantial difference. 170 in no depression, 160 in mild depression, 147 in moderate, and then way down to 117 when you've got the severe depression group. So quite a significant difference. Interestingly, they did not see a huge difference in motility or progressive motility. So the depression seems to be influencing the number of sperm you produce, and that's definitely hormonally mediated, so it makes a lot of physiological sense, but it wasn't actually impacting the speed or the number of the sperm that are swimming. So then in figure 3, or table 3, I should say, sorry, they kind of did comparisons between each group using no depression as the reference group in order to determine all of this. So they looked at this and they said, if you go in the semen volume, it's a decrease that's minimal when you're looking at mild depression. You get a big decrease in terms of the chance that it's going down. Percent change, minus 12%, 12.3% in moderate depression, minus 25.26% in the severe depression category. And again, very highly significant. So per 5 number score decrease, or sorry, increase in your depression scale, you're looking at a 4.4% decrease in the volume. So 25% increase is substantial when you're looking at sperm volume. When you looked at sperm concentration, very similar, highly significant findings. You're starting at a decrease of 11.4%, then 12.9%, and then 18.2%. So very highly significant here. And this, again, is a new model where they mixed in all of the confounding variables to see if it was affecting the things like motility and progression as well. So they controlled for the confounding variables. This is the right way to do it. In the raw data, they didn't see an impact, but here they start to. So when you look at the total count, this starts to get really meaningful. Mild depression, minus 10%, moderate, minus 23%, severe, minus 37% in the total sperm count. And then you start to get into motility, and they're starting to see an effect there when they control for these confounding variables. So minimal when it's just mild, it's like almost 1%, and then 2.5%. But when you get into severe, it's a minus 13.6% in the number that are swimming. And then when you get into the progression, which is how fast they're swimming, or the number that are swimming quickly, again, minus 1.5, minus 2.45 for mild and moderate, but minus 15.08% for the ones that are severe. So what does all this tell us? All of this tells us that in these groups, these guys have very, very significant changes in their outcomes based on the severity of their depression. They did the confounding variable model, again, looking at the various factors in relation to the oxidative stress markers. And again, they did not see any significant element of oxidative stress. So this does suggest that to some extent, the impacts of this are either hormonal or mediated by some other mechanism. But at the end of the day, what's really important here is to know that the mental health of our patients is absolutely critically related to their success. And this is no longer just true for women. This is also true for our guys, because remember, this is an extremely healthy group of men. These are men that are actually coming to be sperm donors, so they already had good criteria. No one has looked at how much more significant this would be if these were men that were depressed and already had male factor infertility. So dealing with the mental health of both the male and the female are really, really important. And we focus a lot on that in our clinic to make sure that our guys are all well taken care of, they feel comfortable, their needs are being attended to from an emotional perspective, from a support perspective. And a lot of times that gets overlooked because we have this kind of macho bravado thing where the guys are tough and aren't talking, but the reality is they need that support too. And so a lot of the relationship component in the dynamics that we see, a lot of the well-being sort of socially, psychologically, it's critical to dealing with this element of what we see in our patients and to making sure that we maximize the outcomes and get the best possible outcome for those patients. Because if you're taking someone who's stressed, who's depressed, you're going to see worse sperm. And then to get that from them and use it, you're not going to get the same outcome you would from someone that's going into it more positive, more hopeful, and with, a better attitude about the whole process. So is depression possibly a negative for men? And does it alter their sperm parameters? It absolutely alters their sperm parameters. And again, this is a study looking at healthy men who already have good sperm. This is likely going to be far worse in men who already have compromised sperm, because on top of their depression, they may have added stress from the fact that they're dealing now with male factor fertility as well. So make sure you like, comment, share, subscribe. Click on that subscribe button, especially on our YouTube channel, and we will be back again next week with another show. We are going to take your questions live now. So thank you for joining us for this part of the show.
First question.
All right.
I'm 9 weeks pregnant from an FET.
Okay.
Prior to the transfer, the embryo was PGTA tested. Should I still go for the NIPT? If yes, what week should I get? Should I start getting NIPT?
Yeah, you probably don't need to. The chances that your PGTA was off are really negligible. It's like 1.3% or so. So it's very, very minimal. There's no harm in doing an NIPT because it's non-invasive. That's what NIPT stands for, non-invasive prenatal testing. So you can do it. We recommend using the American companies because they're much, much cheaper. So I think Fulgent does it, Invitae does it. We now just send all of ours there because the labs in Canada are like $500, but you can do it for $100 US. So yeah, if you want that done, it's super easy to arrange. You just need a blood draw and away you go. But you don't need it. It's likely of no benefit to you. If you're going to do it, you can do it anytime from now. So 9 weeks on is fine. So yeah, you can order your kit straight from Invitae, take it to a lab, get them to draw your blood, and then just ship it.
Got a question from Embryo Math video.
Oh, cool. We love embryo math video. It kind of like, it shot up and then it like hovered.
Plateaued.
It did. It totally plateaued. We haven't gone up for a while. Fire away.
Hi, Dr. Victory. I'm a little confused by the math.
Okay.
You don't recommend PGTA in your other videos, yet it's factored in your math for younger patients and older ones here.
Right.
Why? I'm confused on whether we should consider it. Less so for miscarriage, but more so to prevent conditions tied to the number of chromosomes.
Yeah. So we use it in the video just to explain what you should expect as far as the numbers are concerned. I'm not promoting it for women that are younger. We definitely don't recommend it for women that are younger, but we need it for women that are younger to anticipate how many embryos they will need, how many tries they will need, how many cycles of IVF they might need. I'm not suggesting you run out and do PGTA if you're 32 or 33. In fact, I would strongly discourage you from doing that. But the reality is, when I'm counseling you about it, I need to be able to tell you at 35, for example, 50% of your embryos will not be normal. So if you only end up with 3, we could end up with 1 good one or maybe 2 good ones. I mean, obviously you can end up with all 3 or none, but realistically you can end up with these different numbers. So that's what we are including it there for. It's not to encourage people to do the PGTA testing. It's to encourage everyone to recognize the true numbers that they are dealing with, because the problem that we see all the time, and the reason we made that video, is that patients show up and go to a fertility center where they're told, oh yeah, you're going to be fine. Come do IVF. That's the best thing for you. We'll try. You might need more than 1 try. But what they're not being told is their chance is X%. And I try really hard to tell my patients, this is your actual chance. Like statistically, based on the best knowledge that we have, you should anticipate a percentage chance of whatever. It might be 10% or 5% or 100%. So that's what that video is there for. It's for you to be able to calculate what your chances are, how many tries you will likely need in order to be successful. So it's not to encourage people to do one treatment or another. It's for you to understand how many embryos you will need and how many cycles you will need to get those embryos to end up walking away with a baby. Great question, though. Thank you for asking that.
Got another one for you from another video. Hello, Dr. Victor.
Hello.
You mentioned the ERA is useless. Yet
Yeah.
all the clinics push for it.
Yeah.
Is there another way to see when your implantation window is? I did do it 2 cycles ago, and it came back. I needed 24 hours of progesterone. Yet my 4th cycle failed.
Right.
I have only 2 day 3 embryos left, and out of 4 transfers, I have never had implantation. I realize that there are millions of other factors. I've done all the immune testing, are on Lovenox with transfers, and have been on antibiotics protocol to kill all bacterial and endometritis.
Okay.
Thanks for sharing your knowledge with us.
Well, thank you and hello. So first of all, these are the cases I like to talk to patients about. So maybe reach out to us and we'll do a consult for you. But one thing you didn't mention was whether or not there's endometriosis. I don't know why it hasn't succeeded for you. The other thing I'm not clear about is why you have day 3 embryos instead of day 5. But there's certainly very, very good proof that the ERA test is useless. And what you just said makes perfect sense. You did adjust based on what they recommended and it still didn't work. The ERA test is a waste of time. It's a waste of money. It's a waste of time. Why do clinics push it? Honestly, I am willing to bet you that if you ask your physician who is promoting an ERA test to present you with one study that demonstrates that it's useful, they will not be able to do so. I've actually reviewed in just one video 5 of the studies that showed that it was useless. I think it was 6 actually. So I can show you all the studies because I read them all the time and I look at them, and I even keep track of the newer ones that come out. So most physicians are buying into whatever they're being told. They're not going and exploring this for themselves to figure it out. So I don't just buy into what we're told. I actually go and look it up. And that doesn't mean I don't use it. But I actually really learned my lesson with the ERA test because I did fall for the spiel from the company and thought this was amazing. And then it started to unravel once I asked for clarification on things and evidence. And it was at that point that I realized that this isn't what it sounds like. And then after that, there have been multiple studies which have shown that it's of no value whatsoever. Is there any other way to determine your window of implantation? Yeah, it's really easy. Your embryo should go in if it's a day 5 embryo on day 5 or day 6, and if it's a day 6 embryo on day 6 of progesterone, or after 6 days of progesterone, I should say, so morning of the 7th day, because that's being shown to reduce your risks of miscarriage. So a day 5 embryo can go in after you've completed 120 hours of progesterone or 144 hours of progesterone. It doesn't make a difference. But a day 6 embryo should go in after 144 hours to reduce the chances. What about day 3 embryos? We don't know. That study hasn't been done. I would assume that it's an even tighter window, but nobody knows that. So it'd be very difficult for me to say. I would, however, strongly recommend that you go back to the drawing board before doing this again, because if you failed 4 previous transfers, there must be something going on there. Now, it may have to do with your embryo quality, it may have to do with the transfer technique, it may have to do with the embryos themselves. I don't know. It could be genetics. It could be your immune system still, even though your tests are negative. There are all sorts of possibilities, but don't get transferred again until you get answers, because you need those answers to make it work, for sure.
Any advice on how to improve chances of an FET? The questions are all just rolling into each other.
They're just rolling into each other. Lots of supplements, melatonin, aspirin, vitamin D, probably the fish oils. All of those have been shown to be beneficial. We use letrozole. That's been shown to be beneficial. HCG wash has been shown to be beneficial. The embryo glue is probably beneficial. I'm still not convinced, but it likely is. All of those are good. Make sure they're monitoring you super carefully. Keep your estrogen as low as humanly possible. Ideally, don't take estrogen. The less estrogen you take, the better you're going to do. Use progesterone in oil and vaginal progesterone. Make sure your levels are monitored carefully. You don't want to be too high or too low. Get your lining to be checked all the time. Don't let your lining over thicken, and don't let it be too thin. We usually aim for around 9 millimeters, 10 millimeters when we're starting our progesterone, sometimes a little bit less. I think that's pretty much everything. Yeah, that's the total. Weight. manage your weight, and oh, for the love of God, no smoking, no vaping, no marijuana or CBD or THC products, no alcohol whatsoever. Stay really calm. Acupuncture, traditional Chinese medicine, naturopathy, super healthy diet. The Mediterranean diet has been shown to be beneficial, and that's actually been proven.
What happens when we take Luzon injections?
Lupron injections?
It could be it's a Z, but I'm sure it's Lupron injections.
Luzon, okay.
Yeah, let's go with Lupron. Injections for surgery, and if I have to delay surgery, do I need to take injections again? Can I delay surgery? I took injections already before almost 2 months.
If you're referring to Lupron injections and surgery, it doesn't do anything. It might make the surgery easier. It depends on what we're doing. Endometriosis, it would make it a little bit easier. For fibroids, I don't find a difference, but there are cases that report that it's harder. I don't actually find that at all. But I'm not sure if you're referring to Lupron or not. So if you mean like a heparin type of drug, that's a different story. You got to be off before you do surgery. But if you're referring to Lupron, you should be fine. No worries there.
Does the subjective grading of an embryo matter if the embryo is genetically normal, confirmed by PGT testing?
Mm-hmm. We reviewed that about 2 months ago. There is still a difference. So even if you have a PGT-A euploid genetically normal embryo, but it's a CC or a BC or a CB, once there's a C involved in there anywhere, it won't do as well as a BB or an AA will, or anywhere B and up.
Oh, I'm 39. I've had 4 failed transfers. Currently, I have a couple euploid embryos and some untested. Would it make sense to transfer euploid and untested in a DET, or just stick to SET for euploid?
It would make sense to figure out why you haven't succeeded yet before you do anything. If you can find a reason, then I would suggest that you consider, going back at it again and doing just one. If you cannot find a reason, then I'm going to question why we're doing it again and again and again without success. I am never a believer in repeating the same thing over and over and over again just because you anticipate that if you try enough times, it'll be successful. There are a lot of studies that support that approach to things, and there are physicians that approach things that way and support that as well. I think it's a money grab, to be honest with you. It just doesn't make sense to me. Like, if you're just doing the same thing over and over again that hasn't worked, there has to be something wrong. Address the problem. And I'm not saying that you need to charge people a fortune for whatever you're addressing it with, but you got to figure out what's wrong. Just to keep putting embryos back in makes no sense to me whatsoever. So whether you're checking your immune system, checking for endometriosis, checking for infections, checking the embryo quality, seeing what went into it. Was there smoking, drinking, drug use for either of you at the time? Was the DNA fragmentation high? What kind of ultrasound are they using when they do your transfer? Are they really getting a good view? Is your center capable of doing transvaginal guided ultrasound embryo transfers? Because those make all the difference in the world. So all of that can be really, really important for you.
Instagram crashed off my phone.
Uh-oh, you need mine?
No, it's good, but the questions are...
Oh no, that happened last time too.
Yeah.
Dude, I need to get you a new phone. I'm picking up my new phone tomorrow, actually.
Really?
Yeah, but they didn't have the 512 or the 1 terabyte.
Oh, you got
256.
Really?
Yeah.
So
Sad me. We're going full techie on you here. So, are you sure you don't want mine?
No, just tell them.
Okay, so folks, if you're watching on Instagram, apparently Instagram crashed on us over here. So just re-ask your questions. Sorry. But we'll pay special attention to the Instagram questions.
Yeah, we'll give them priority.
You don't want me to just pull it up?
Yeah, they're not there. If you don't watch it live,
they're all gone. Gotcha.
So, hey, Dr. Victory, when a woman has a miscarriage, do you expect for them to work the next 2 days, or should they rest their bodies for a minimum of 3 weeks, also for emotional reasons?
I think a woman should do whatever she feels comfortable with. You don't need to rest biologically, But if you feel mentally like you need to, or physically, if there was a lot of bleeding, then do whatever you feel is right. We certainly support every woman's experience of a miscarriage as being very traumatic. So I support my patients. If my patient says to me, I need time because I'm struggling, then we give them time. So yeah, I mean, anything reasonable is perfectly fine. You know, would I give someone 6 months off for a miscarriage? No. But if they needed a couple of weeks to deal with the grief of a loss, in particular when it's a fertility loss, not to disparage any other loss, I'm not saying one's worse than the other, but fertility patients are dealing with the prior trauma of having infertility, and then you add a miscarriage onto that, so it's like an additional burden. Yeah, I mean, I think having time off is completely logical and reasonable, and we deeply sympathize with all of our patients, so I support that totally.
Very interesting question.
Okay, on the gram?
No. This one just, it's old. I'm doing order. I was watching.
Okay.
Hi, Dr. Victory. Will you be offering IVF gender selection when you open a clinic in the US?
Oh, I haven't even thought about that. Probably you have to because it's allowed there, although I really don't feel comfortable with that. So that's a complicated question. The other part of that that's complicated for me is I could potentially get into trouble with the Canadian college if a Canadian patient came to me in the US asking us to do that. So I would probably pass all of those cases on to an associate, and we will have an associate there. I, in fact, will likely be managing there, but not doing as much personal work there. We have a doctor hopefully lined up to work with us there. So once that's up and running, I think that individual would do all of it.
I would do it this way.
Tarek's willing to take over. Yeah. You could probably do the consults by now. You've heard enough.
I know a little bit.
Yeah.
I know a little bit.
He knows a little bit. He can correctly answer the questions. He's kind of like mouthing the questions off to the side most of the time. So
how much melatonin do you recommend taking daily?
3 milligrams.
I know you suggest taking aspirin for an FET, but when I asked my nurse, I was told don't need it. I don't want to do everything right I want to do everything right for this FET. I'm CD1 today and started letrozole and Z-Pack on Thursday.
Yeah, take the aspirin. Yep. Take your aspirin. It's always good. There's no reason not to take aspirin. So aspirin improves the success rate. So there's no reason not to.
I got
a doozy?
Yeah.
Okay.
Could you share a most inspiring story from your clinics?
Oh, wow. God, there are so many.
What is a doozy?
That is a doozy. I'll tell you a fertility story that is very inspiring for me, and then I'll tell you about another one as well. So I'll give you two. So we had one couple who shall remain nameless, but they know who they are. And they struggled with infertility for a very, very long time, years and years. And we tried all sorts of stuff for them. We tried IUI, we tried IVF, really difficult course. And this was years ago. And so finally, we were able to achieve success for them. And when we did, they ended up finding out that the baby had Down syndrome. And they decided to keep that baby. And after all those struggles, it's often very difficult for parents and patients to deal with that added level of stress. And these folks have now made it kind of part of their life mission to show how joyful and how wonderful and how incredible it can be to parent a child with special needs. And they're like totally my heroes. I mean, I have nothing but love and respect for them. They are absolutely phenomenally strong, wonderful people. And so that was really, really an amazing, thing for me to watch. So they're totally my heroes. Mentally, they always stick in my head as being, some pretty incredible people. One of the other families that are very near and dear to me are a family who also struggled with infertility, and they wanted to help others. So one of the couple actually set up to do a run, but the run was 100 miles. Nonstop. And so he ran like crazy. And I started the run with him and died a few minutes into it. And that family has had a lot of ups and downs in their own life and in their fertility struggle, but they were totally inspiring to me because of what they did. So we get the chance to meet some truly amazing, incredible people. And, there are a lot of people that have had struggles of their own, who have turned those struggles into opportunities to help others. We have people that have started charities and people that have started foundations where they donate to other couples with infertility. And I just find that so incredibly amazing and rewarding. For me to be part of that, to see someone take their trauma and their grief and turn it into something that helps alleviate the trauma and grief of others. So we have so many of those stories. I'm probably missing out on tons of them, but those are some of the most inspiring, empathetic, stories I can think of for sure right now. We've never been asked anything like that. That's kind of cool. Yeah. Yeah.
Follow up to your aspirin question. Only one baby aspirin a day. What time of day is best, and why would my nurse have told me not to take it?
Not sure why your nurse told you not to take it, but if you're with us, I'll definitely have a chat with all my nurses because they should all be telling you the same thing. And as far as the dose, 81 milligrams, and as far as when, it makes no difference. Doesn't matter.
Hi, Dr. B. You said that you don't like to disturb the homeostasis in the first trimester.
Yeah.
What week would you stop progesterone supplements for your patients? Do you gradually wean or just stop at some point?
So we actually continue progesterone, but we wean at the same time. So we stop progesterone in oil at 12 weeks if you're doing IVF. And then we cut the vaginal dose in half, and we keep our patients on it till 36 weeks because I believe it reduces preterm labor. So luckily, we do have a relatively low preterm labor rate in our practice, and it seems to work really well.
I have had 2 saline HSGs and having a third one on October 25th.
Okay.
I am one of the rare cases that find the procedure to be very painful.
Sure.
My first question, is the intense pain an indicator of something bad or negative? Second, is there something a little stronger than Aleve to make me more comfortable for my next procedure?
So first of all, the SIS should never be painful for you if it's done right. So watch our SIS video on YouTube. It doesn't have to be painful. And I walk you through step by step. Warm the instruments, talk to the patient, don't overinflate the balloon. Use warmed saline, go very, very slowly. There's no reason why it needs to be painful, really. Like I never hurt patients when we're doing the SIS. As far as what can you use for pain, you can use anything. I mean, if you find it severely painful, take Toradol and morphine, take Toradol and Dilaudid. Like you can pretty much get not quite knocked out, but pretty close to knocked out, and do an SIS. Yeah. I'm not advocating drug use, just comfort. Comfort's good.
Could taking too much melatonin, 10 milligrams daily, cause an FET to fail?
I don't know that it'll cause it to fail. It's a lot of melatonin. The majority of the studies have looked at 3 to 5 milligrams. So there is one study that looked at 10. You don't need that much, so I wouldn't go that high.
Also, how long do I take the aspirin for? Sorry, so many questions. I'm desperate for success.
The whole pregnancy. Don't stop until you're holding your kid.
Somebody give a comment on the nurse. I couldn't read it.
Okay. Uh-oh.
You're happy you're a doctor today. Is the Lupron Depot injection supposed to prevent your cycle from starting when preparing for FET? Is it okay if your cycle did begin?
No, it doesn't always stop your cycle, so that's not super critical.
Hi, Dr. Victory. Can you do timing intercourse if you have adenomyoma, and can you get pregnant?
Yeah, I mean, an adenomyoma can make it more difficult to get pregnant. It doesn't necessarily stop you from getting pregnant. Nevertheless, timed intercourse, yeah, of course. I mean, as long as it's not blocking your tubes or something like that, you're fine.
Technical question.
Okay.
What are your thoughts on metformin as a metabolic stabilizer in general?
In someone with no PCOS or diabetes, it's probably aggressive. But if you have insulin resistance, if you have metabolic syndrome, if you have PCOS, you are diabetic, it's totally reasonable and indicated.
Is ibuprofen allowed during an FET up to the point of transfer? Also, what's the rule on intercourse leading up to transfer?
No, ibuprofen's actually been shown to be detrimental. Intercourse is a great idea because it primes the lining to be prepared to improve the chances of the embryo sticking. So you should have unprotected sex leading up to your transfer. Just please not right before the transfer, because then we got to clean out all that ejaculate. It's nasty.
Is aspirin only indicated for IVF or spontaneous pregnancies as well?
It depends on your history. I mean, if you watch our aspirin video, it's one of the more popular ones on our YouTube channel. It runs through all the benefits because we reviewed the study on it there. So I forget what that one's up to now, 14, 15, it's a 17,000, something like that. So yeah, check out that video. It explains it all. But yeah, I mean, it reduces preterm labor. It probably reduces preeclampsia, improves blood flow. I believe it reduces miscarriages. That's super controversial. So yeah, I mean, check it out and see what you think.
I'm wondering what it means to have WBC in a sperm sample and what issues could come from this. We've been told to both take antibiotics for 2 weeks and redo the test after treatment.
Yeah, it usually just means that there's some exposure to inflammation or infection, and that could come from anything. A lot of guys have some underlying infection in the sperm. It can come from some prostate infection or epididymal infection. So yeah, I mean, we're trying to eradicate that to allow for improved sperm performance. If your sperm is chock full of white blood cells, it means there's a lot of inflammation in there. That's obviously not a good thing.
Can you explain your immune protocol or FET and how it is different than a regular FET protocol? How does it work? What are the benefits?
Well, first of all, you shouldn't do an immune protocol unless we think you have an immune problem. And there are different ways to do that. There's tests that can be done, or at least based on clinical suspicion or your history. But really, it should be done after testing. We customize our immune protocols to our patients. So I don't use the same kind of protocol for everybody. But there are different approaches. Some of the standard ones, steroids, intralipids. We actually use heparin because it's an anti-inflammatory. So those are sort of our mainstays. Aspirin's in there as well, the vitamins, the supplements. The more aggressive stuff is things like subcutaneous IG, the sirolimus we learned about 2 weeks ago. 2 weeks ago, was it? Yeah. We did that one 2 weeks ago. So we're going to start trying that as well. Plaquenil can be used. That's been shown to be beneficial. Tacrolimus has also been shown to be beneficial. So there are a lot of different things that can be done, but it's a case-by-case situation. We don't just have one protocol. You really need to customize this stuff. There is no cookie cutter medicine that works in infertility. It's number one rule we always have. Our standard line here is we're making babies, not cookies. So cookie cutter medicine doesn't work.
Are there any other supplements that should be taken other than prenatal when trying to conceive naturally?
Yeah, all of the same ones: melatonin, vitamin D, iron if your iron is low, sometimes coenzyme Q10, the fish oils. All of those are helpful. There's nothing wrong with taking baby aspirin. It's probably beneficial. Same thing for the guys, lots of vitamins, and then healthy diet, lots of exercise. Those are certainly the basics. If you have PCOS, NAC and inositol, coenzyme Q10. If you have endometriosis, NAC, coenzyme Q10, and curcumin, which is turmeric, is also very good.
So no Advil for my cramps and headaches on cycle day 1.
No.
It can already have an effect on my transfer, which is likely weeks away.
Yeah, don't take Advil. You're not supposed to take Advil anytime around your fertility. Sorry. You can take Tylenol, just don't take Advil.
That is all the questions we have at this moment.
We stumped everybody tonight.
I think
Wow.
there's some questions that vanished.
There's more coming.
There's always more coming. And they're late to it today.
There you go.
Follow-up. Can you explain what immune protocol means? Is it to boost the immune system, prevent something from recurring?
Oh,
Are
no.
they drug injections or oral medications?
So some of them are infusions, some of them are oral, some of them are subcutaneously injected into your fat. Most of these are designed to help calm down your immune system, to decrease the activity of your immune system so your immune system doesn't attack your embryo. You want to make the uterine environment more tolerant of an embryo implanting there, because you want to try and get the embryo to be happy and grow and develop. So it's a lot of kind of help the embryo relax and enjoy its stay and make it like you want a spa environment for your embryo. So to do that, you need tranquility. And so the immune protocols are designed to calm your immune system.
What is the difference between regular TSH levels and TSH level for fertility? Just started on L-Troxin.
For fertility, to optimize the neurodevelopmental outcomes of babies, you want your TSH less than 2.5. When you're not trying to get pregnant, anything under 5 is fine. Now, some people will feel not great if they're 4.8, 4.7, 4.6, whatever, but you don't need it lower than 5 in most circumstances. But for fertility, in order to maximize fertility and to improve the baby's outcomes, you want it less than 2.5.
When can I start trying again after a miscarriage?
Right away.
And DNC?
Right away. You do not have to wait. That's been studied, and there is no need to wait. So if you get a period, you can go ahead and try.
Approximately what cycle day dose the transfer usually happens? I have a wedding to attend at the end of the month, and I'm trying to determine if my transfer will interfere.
Takes about 2.5 weeks on average, maybe up to 3.5 to get you ready for an embryo transfer. That's hilarious.
I really like that.
I love it when we have to schedule around the events. I mean, obviously it's part of life. So people don't necessarily want it to interfere. From our perspective, it's this huge momentous event. And we totally lose sight of the fact that people also have a life outside of what they're doing with us. So thank you for making it real, because it's good for us to remember that, you have something outside of just having embryos implanted in you. And that's really hard for us to remember, but it's really important for us to remember. So thanks for bringing that to our attention, because it's a good reminder, and I got to do a better job on that one.
Does being on immune protocol make you more susceptible to infections like common cold?
No, not at all. Immune protocols are not aggressive enough to suppress your immune system. They're calming your immune system. They're not going to overdo it to the point where you're now at risk for getting something.
Regarding CoQ10, is it safe during pregnancy or just for egg retrieval?
Your body naturally has loads of CoQ10 in it, so you can take extra. It's not going to do anything. It's totally harmless.
I'm from Edmonton, and I had a couple consult with you a few weeks ago.
Sure.
Just curious if you have an open door policy where I can get a hold of you for any questions I may have moving forward without having to book another consult. I don't have Facebook or Instagram either. Thank you.
If I consulted with you, you're welcome to just contact the office and we'll set up another appointment for you. So yeah, don't hesitate. I'm happy to reach back out to you. Absolutely. Don't hesitate.
This is a great question.
Okay.
My doctor used Prograf, which is
Yeah.
very similar to the sirolimus drug.
Yeah.
Prograf is much more cost effective than the sirolimus. I had a successful FET but miscarried at 9 weeks. I plan to use the same protocol. Again, just asking your thoughts.
Yeah, so I don't have any experience with the Prograf, but that writer actually messaged me or left a comment for us.
Yeah.
So I'm certainly going to look into it. We have an incredible pharmacy team. So I will run that by Kinga and her minions and let them figure that out for us. I mean, sirolimus, when I looked into it, it sounded like it was going to be about $500 for a treatment. So I think that if we can get it for less with whatever Prograf is, I'm happy to check that out. Maybe we can check out what Prograf is and see. I'll do that while we're still answering questions. Fire away, yeah.
How much CoQ10 a day for FET? With my cocktail of supplements I take each day, I'm wondering if there are any that shouldn't be taken together.
600 a day, and there are no supplements that shouldn't be taken together. So Prograf is tacrolimus, which I mentioned. Actually, tacrolimus and sirolimus are different and work in different ways. Tacrolimus does not work through the mTOR pathway that sirolimus does, but it has been shown to be beneficial for patients that have recurrent implantation failure. So it is a very reasonable thing to do. Yeah, I've got no trouble with using Prograf. I didn't realize that's what Prograf was. I had mentioned tacrolimus just earlier. So yeah, that's a very reasonable approach. Nothing wrong with doing that.
Is Valtrex okay to take during pregnancy?
Valtrex is totally okay to take during pregnancy for women that have recurrent herpes outbreaks or have herpes outbreaks in their pregnancy. We suppress them with Valtrex from 36 weeks on so that at the time of delivery, there is no active herpes outbreak, because if the baby is born vaginally and you have active herpes, that is an unholy nightmare for the baby. So it actually helps prevent that from happening. Yeah, we use it all the time.
And this is your last call for everybody. Let them know.
Okay, last call. You got 8 minutes left. I guess it's a quiet night for some reason.
Is pomegranate juice beneficial while prepping for an FET to think in your life?
No clue. No evidence on pomegranate juice that I'm aware of. I doubt it's helpful or harmful. It's probably neutral. Yeah. I don't think that's an issue. We keep stumping everybody tonight. You know what? Maybe we get a bonus night for, all the nights where we stay here for 20 minutes extra. Yeah. Listen, we had lots of controversy recently from a post, and I would like to address that. So I put up a post about all the very, very unfortunate women that have succumbed to COVID-19. And there was lots of controversy about getting vaccinated and not getting vaccinated. Your risk of complications from COVID, if you are pregnant, are off the charts high, including, God forbid, death, which is 22.3 times higher than in a patient that's not pregnant. Will the vaccine protect you? Yes. Is it 100%? No. But is it going to reduce your chances of ending up in the ICU? Absolutely. And that is crystal clear, because if you look at the data on the women that are going into the ICU, they're all, or the vast majority of them, are unvaccinated women. Is there a risk to the vaccine in pregnancy? Zero. Is there harm to your baby from the vaccine in the pregnancy? Zero. Is there a harm to you from the vaccine in the pregnancy? Extremely, 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 extremely low chances that anything bad will happen to you. Can it cause a miscarriage? No. Can it cause any kind of problems? No. So please, 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 please stay out of the ICU, because the last thing on earth we want to do is lose innocent people to this crazy virus because of all the nonsense on the internet for people that think that it is going to kill them. One of the most staunch anti-vax people I know just went and got vaccinated. So believe me when I tell you, this was someone that was raving about all of the conspiracy theories that are out there and how horrible the vaccination is, and they went and got vaccinated. So don't wait, because COVID can be deadly, and if you are pregnant, in order to protect your baby, you should be vaccinated. Anything left?
Hello from London Fertility Concierge. Since it's a slow night, I'll just say hi to you and Tarek.
Oh, hey. How are you, Mel?
Got my first shot on October 1st. Thank you for the push.
There you go. Good job.
And then some really positive comments. Thank you for watching and not seeing this. You need to make him your doctor. He's absolutely the best. Love your doctor.
Well, thank you very much, everybody. We hope you have a great night. If you're in Windsor, try New Kirin Chinese food. Tarek and I had a great meal tonight. This is not a promotion or an ad. It was just really good food. So they had some amazing, amazing food. And we enjoyed that. I hope you guys have a great night. Take care, be well, get vaccinated, and we'll see you again next week on Fertility Fact or Fiction.